Well, let me sort of give a brief synopsis. I came here to the University of Minnesota in 1960, September 11th, 1960, when I got out of the Air Force. And I came here because the University of Minnesota was, and in particular the Department of Surgery, was a fulfillment of what had been in my mind as a dream, only here it was a reality. I grew up in New York and went to school in New York in Columbia College, Columbia College of Physicians and Surgeons for my MD, Columbia internship, and then the Air Force. Now, throughout this time period, I'd always dreamed there must be a place where you can learn to be and then be an excellent clinical surgeon, take good care of your patients, be a good technician in the operating room, and at the same time have the opportunity to do basic research and clinical, or they call today translational research, and teach. And there were very few, if any, such avenues on the East Coast. When I went to school there, the surgeons were generally looked upon as the people you point to the operating room, tell them what to do, and then somebody else takes care of the patient. They didn't rely on the surgeons to have a cognitive ability. So I thought there must be somewhere, or at least that was my dream. And then I found out that a Dr. Wangensteen, here in the Department of Surgery at the University of Minnesota, ran such a program. And I came up here while I was stationed in Omaha, and indeed he did. I found some of my old friends here that I knew from the past, and they all confirmed that this was a program to educate academic surgeons. That instead of a 5-year standard clinical residency, the residency was at least 7 years, 6 to 7 years, since I'd already done 1 year internship, where you spend at least 2 years doing basic research and getting another degree, a master's in biology, physiology, whatever. Mine was in biochemistry, and then graduating with a PhD in surgery. And that's what I did. And then I had the privilege of being asked to stay on the faculty, and that's where I've been ever since. So I joined the faculty in 1966, 67, and I'm still on the active surgical faculty. And I've had a wonderful career as a clinical operating surgeon, and I'll get back to that. And what has my work been in? Well, I think I can divide that into several phases. My first major interest was high cholesterol and its relationship to atherosclerosis. And while still in the laboratory, working together with a senior professor, Richard Varco, I established a laboratory, and I had a real privilege because Wangensteen and Varco allowed me to have my own laboratory while I was still a resident. I don't know if that was ever done before. I don't think it's ever done afterwards. And out of this came some very basic research work in cholesterol and bile acid metabolism, and an operation, a partial ileal bypass operation, which bypasses the distal third of the small intestine and is still today the most effective means of lowering cholesterol. It's not used much today because we have the statin drugs. And the first clinical procedure I did in 1963, and then in the early 1970s, we obtained the program on the surgical control of the hyperlipidemias grant from the National Heart, Lung, and Blood Institute of the NIH. And this was, and probably may still be, the largest investigator-initiated grant. It wasn't a contract that the NIH puts forth and says you apply. This was investigator-initiated. Was in 4 institutions. It came to about $65 million when it was all said and done. And we showed that lowering cholesterol with this partial ileal bypass operation, for the first time ever shown, we published this in 1990 in the New England Journal of Medicine, it actually prevented a second heart attack or myocardial infarction, increased life expectancy, decreased peripheral vascular disease, and abated many of the other cardiovascular events that are associated with atherosclerosis, which in turn is a product of hypercholesterolemia or high cholesterol levels. In addition to the clinical aspects of this program, we did a concurrent arteriographic study, and we showed by doing coronary arteriograms that lowering cholesterol not only retarded the advance of the disease of atherosclerosis, but actually caused regression. Excuse me. Actually caused some loss of plaques and a return to more normal coronary anatomy, all in patients who had already sustained one heart attack. So that was sort of a line of work I pursued. And interestingly enough, now many years after formal trial closure in the 1990s, we are still harvesting data from this POSH trial. And the most interesting piece of data that we recently have put out for publication is that this operation to lower cholesterol actually may interfere with the onset of type 2 diabetes. And we're studying this further. Now, if this becomes a reality, then one could do a very simple operation through a little tiny incision or laparoscopically that could simultaneously lower cholesterol and ameliorate or abate type 2 diabetes. Oh, it's sort of a capsule of the first major area that I've worked in. The second is I got together with the engineers. The engineering aspects of medicine interested me very early. And it's not taught in medical schools, or wasn't taught. It's now taught. Body processes in health and disease were looked upon from a chemical perspective, or biochemistry, from a physiologic perspective, or physiology. But no one looked at it from an engineering perspective. And there are so many engineering principles involved in bodily processes. Let's take the previous subject we talked about, atherosclerosis. Plaques in arteries form at certain places. And you have to ask yourself, why? Well, there's a different flow rate. There's eddy currents. There are fundamental engineering or physical equations that describe why certain things happen. And to view some of the flow characteristics and other characteristics of human beings, in addition to the chemical and the physiology aspect, as an engineering aspect, wasn't done. So a group of us got together in surgery with a group in engineering, and we started the biomedical engineering faculty. Faculty means nobody gives you any money. You have to have an appointment in some other department. Out of this faculty grew the biomedical engineering department, which is now one of the hugest departments in the university, gives a joint degree program with a medical school and an MD and a PhD in biomedical engineering, one of the largest research buildings and office buildings and several other research facilities are now biomedical engineering. And so it's come a long, long way. And I've always cherished my second appointment as a professor of biomedical engineering. And once this was done, we had a laboratory, of course, and out of this laboratory came the prototype for all the implantable ports that are used throughout medicine today. And the first implantable infusion pump, and another infusion pump, and various catheters where you wouldn't get backflow, and shunts. So we had a wonderful time inventing things. A method for oxygen transport analysis, finding out how fast oxygen is transported. And that is something that we're actually put in a grant for now, that to work further with this in blood banking, to give it a practical application. People who come into a blood bank all have different oxygen transport based on their age, their cholesterol level, many, many factors. And a blood bank can sort out the ones with the fastest oxygen transport and use that in emergency rooms for acute trauma or on a battlefield, and then use the other blood for more routine transfusions. And so we've just put in a grant to work on this further and work with the blood banking people. So that's sort of been an interesting aspect of another one of my things that I do here. Oh, and we've also now developed a access device where you can put this into the abdomen or other areas, and it expands. It's self-lit, and so you can work in a field through a very small opening and then open up to a very large self-lit field. Well, then we get to the area where really I've done the most work that people actually know me for at this point, is metabolic bariatric surgery, which means originally it meant operating for obesity, but today we look at it for operating for metabolic diseases, obesity being a metabolic disease. And I got into this very, very early in 1966, and for the last 20 or so, 25 years, it's been the main thing in my clinical operative career. And this field has come a long way. There are well over 300,000 metabolic bariatric operations done annually. We have found that these operations also resolve diabetes, hypertension, high cholesterol levels, obstructive sleep apnea, and many, many of the other comorbidities or diseases that come with obesity. And the field is now taking another turn, namely the search for operative procedures that don't cause weight loss and would be applicable to an overweight or normal weight population and use these procedures as a simple way to avoid drugs. And, well, drugs are all palliative. You've got to keep taking them into the future. But maybe resolve, I hate to use the word cure, diseases such as type 2 diabetes. The field has expanded. I've had the privilege of being the president of the American Society of Metabolic Bariatric Surgery and the International Federation of Surgery for Obesity and Related Diseases. And it's expanding throughout the whole world. And one reason it's expanding is because obesity is expanding. And the diseases of obesity are expanding, such as diabetes. There are certain areas of the world where, almost 45–50% of our population in the United States is overweight. And there are areas in the world where 15–20% of the population is actually obese and morbidly obese. The incidence of obesity, let's say the number of obese people, is highest now in India. You think of Indians from India being very lean, but there are a lot of them. And if you take a percentage of them that are obese, there are a lot of obese. China is coming up there. And another area of the world, of course, is the Pacific Islanders and the Middle East Arab countries have a great deal of obesity. So this is a burgeoning field, and the fact that we realize that our operative procedures are metabolic in what they do, they change hormones, they change neurological mechanisms, and the fact that we may be able to take care of diseases in people who are not obese is making this a very much appreciated and upcoming field in the world, as all of metabolic surgery, I think, will become a major area in surgery. And I'll stop after I just say one more thing about that. How did surgeons start? We did incisional surgery. Somebody had a boil, we cut it and let out the pus. And then we did extirpative or removable surgery. When I started in surgery, that was the major thing. Bigger and bigger operations, mostly directed at cancer. And then came reconstructive surgery, open heart surgery, valve replacements, reconstructive knee and hip surgery, and so on. I think we are now solidly in the era of metabolic surgery. And my late partner, associate friend, Richard Varco, and I defined this in a book that we published in 1978 as operating on a normal organ or organ system to achieve a biological goal for the benefit of the patient. So let's go back to that partial ileal bypass operation I talked about. You bypass the distal third of the small intestine, normal intestine, but the cholesterol goes down. Atherosclerosis recedes. Metabolic bariatric surgery, you operate on a normal stomach, normal vagus nerve, normal small intestine, and people lose weight. Not because of the anatomical changes per se, but because they induce a metabolic response in the patient. The advantages and disadvantages of metabolic surgery, in, let's say, in comparison to drugs, is the pharmacy industry tries to focus a drug to a narrow area of action. It either activates something or blocks something. If they have a broad spectrum, then they have side effects. And it is the purpose of most drugs to have a very narrow spectrum to fulfill that purpose without side effects. And therefore, it is very difficult for pharmaceuticals to be effective against, let's say, obesity, because it has so many factors that cause it. And if you shut down one factor, there are other factors that take over. There's so many compensating elements that make a person become obese. Surgery is more of a shotgun effect. We hit a lot of different areas. And on the one hand, it's better because we do hit all these areas, and therefore we have a better impact. And though some patients regress, we have a much longer impact. And on the other hand, we still have to figure out what we're doing. Whereas the pharmaceuticals are generally, you know what they're doing. But with surgery, we're not clear what we're doing. But we have a major impact, and that's the challenge for metabolic surgery, is to appreciate what we're doing, and then maybe this will open up the secrets of what the diseases are and maybe lead to non-surgical therapy.
You mentioned one major turning point in your career, the earliest one maybe, where you decided you wanted an academic program that was also a surgery program. Mm-hmm. And that led you to Minnesota and started everything off. Had you stayed on the East Coast, things would have been presumably different because the research opportunities would not have been there.
Right.
I'm curious whether you identify any other turning points in this story you've told. Places where you happened onto something, or you made a decision, or you turned in a direction that was fruitful.
Well, I guess there were two other turning points. I consider it a turning point, but I'd always been interested in medical school in atherosclerosis and cholesterol metabolism. And you ask me why. I guess it's the old Willie Sutton philosophy. If you remember, Willie Sutton was a bank robber. And they asked him, Mr. Sutton, why do you rob banks? And he said, that's where the money is. Well, when I was in medical school, the dominant epidemic in the world was atherosclerosis, heart attacks. And people didn't quite understand what was happening. Coronary artery surgery wasn't really being done, and so it's a field that interested me for a long, long time. So I wouldn't say that was a turning point. But my partner, who I mentioned, Richard Varco, had done the first obesity operation in 1953. And in 1966, he wanted to get back to it. And unfortunately, he'd cut the median nerve in his arm, and he couldn't operate. And so he asked me to get into the obesity surgery. And I refused. I said, my name is going to be associated with cholesterol, and if it's going to be associated with obesity, I don't want that. I want to have a focused area. Well, he kept after me. And one day he had just gotten a new cast on his arm. And we met in the hallway, and he waved his arm at me furiously, and he said, if I could operate, I would, and you can and you won't. And I said, okay, I'll do it. And so I started that aspect of my career. I must have done well over 4,000 bariatric procedures in my lifetime, and I've never regretted it. The first thing I learned to do was empathize with the people who were obese. realizing that they had a disease. This wasn't gluttony. They had a problem. And as a disease, it was our obligation as physicians to try to cope with it. And then I've spent so much of my lifetime fighting the prejudice against this, because everybody's prejudiced against obesity. Payers don't want to pay for obesity surgery, obesity treatments. Governments don't want to have any part of it. Fellow physicians looked askance at obesity surgery. Our fellow surgeons looked askance when we first started. And the public is prejudiced against the obese. Though up to 50% of Americans will be obese very soon, they still look down upon obesity. So it's a very hard prejudice to cope with. And it takes time and patience and education. So I guess that was a turning point of saying this is also going to be a field of mine, taking care of the morbidly obese, and then transforming that interest into, these people have a metabolic disease. We have one metabolic operation now that came out of our shop here, the partial ileal bypass for hypercholesterolemia. Let's look upon this as a metabolic disease and see what else we can do. Maybe this is a way to approach diabetes, high blood pressure, and so on. I guess the next point, turning point was when, during the time period when I was a resident, and was going back to school, so to speak, in order to get my degree requirements, I thought there was something missing in that curriculum when you looked at bodily processes and functions by a biochemical perspective, a physiologic perspective, a histologic perspective, an anatomic perspective, and nobody was looking at it from an engineering perspective. And I always thought there were so many things in a body that could be analyzed from an engineering perspective, and that is certainly not original. Leonardo da Vinci did this a hell of a long time ago. And then I found some like-minded people in the Department of Surgery, Richard Varco, Dmitry Nikolov, and like-minded people in engineering, Perry Blackshear. And we started this concept. And it's now fairly well spread around the country, is to do biomedical engineering. And that approach, that perspective, that view, sort of a different lens to look at things, I think has brought medicine further. So maybe those are the two turning points.
Friendships seem to be important in your story, especially this friendship with Richard Varco. Can you say a bit about how those friendships and collaborations worked?
Mm-hmm. Well, I think friendships are important. Because, and that doesn't always mean that the friendship is built upon similar viewpoints or likes. Friendships can very often be elicited or originated through different perspectives and arguing different perspectives. And out of that, maybe some of the best friendships ensue. A respect for other people's opinions and the pleasure of an intellectual controversy, and then resorting to a scientific way of solving it. So, yes, I would agree with you that it is important in a productive academic life and any life to have friendships. Friendships are more than the pleasure of knowing another person. In professional friendships, I'm not talking about personal friendships and love for your family, but professional friendships are a stimulus to thought, are a stimulus to cooperative ventures. For instance, right now, we're going to pursue this idea of, does the partial ileal bypass do something to mitigate type 2 diabetes? So what did I do? I picked up the phone and called 3 friends at Harvard, East Carolina University, and Cornell, and said, join me in this project. They said, oh, absolutely. And so, based on a friendship, we have a project. I didn't have to sell them. I told them this, I thought this was a good idea. How about joining me? Absolutely, we'll do it. And so, friendships are important.
You mentioned at the beginning the prejudice about surgeons that you encountered as you were coming out of the armed forces. Surgeons are, the image is a little bit like they're those dogs you send to go fetch the bird. they're technicians, and how that limits what's possible in surgery. I wonder whether, I mean, right now there's a surgeon, a superstar image out. I don't think anyone would think of surgeons as simply technicians in the wider public anyhow. I'm wondering if you see issues and problems with the contemporary image of surgeons, or the contemporary mindset of people who go into surgery.
Well, I think the things that started here in the Midwest started on a very original note. The traditional surgery of the East, and still most of the East, was as we've said, the surgeon is a technician. Somebody does his thinking for him and tells him what to do, and then he goes and he performs. The cognitive thinking, research-oriented surgeon certainly spread from this institution to many others, Michigan, Johns Hopkins, Duke, many places. The old concept is still very much alive in some other places. And when you say today there's been sort of a godlike status attributed to the surgeon, I'm not so sure that's true. But there may be, based on the economics of today, a retrogression in thinking, because the surgeon can command a certain amount of income for their technical feats in the operating room that commands greater reimbursement than seeing people in a clinic and talking to them. And since today medicine on a whole is becoming so much group activity rather than single practitioners or single bodies of surgeons, internists, they're all sort of becoming integrated in academia and out of academia. There is the tendency today to put the surgeon back into the operating room as their primary role to earn money for the group, so that the others can sit and talk to patients and do the less remunerative aspects of medicine. obviously, as a surgeon, I have been an academic surgeon all my life. I don't think that's good. I think surgeons belong in the thinking part of the medical community as well as in the technical part.
Thank you. I'm sitting here with you today because I had a conversation with Emily Buchwald a while back, and she said, "You really got to talk to Henry, and if nothing else, in order to provide a record for the family of this interaction." And so, kind of in deference to that, I guess I should ask about family and career and the way those, I mean, for some people they don't work together very well, and for other people it makes perfect sense. How's that been for you?
Well, Emily and I got married very young. And there was never a question of her not having a career, and only me being the old-fashioned, traditional career wage earner. That never entered our thought processes. In a way, we sort of changed career perspectives. Originally, I wanted to be a writer. And I soon gave that up for science, and then that converted to medicine. But I still didn't know what I wanted to do. I loved everything that I learned. I loved learning. I loved going to school. But nothing said to me, this is where you want to spend the rest of your life. In essence, I took a lot of work in philosophy of religion when I was in college, and I was offered a fellowship, and I said, that's not what I do. I'm not a seminarian. And I got to medical school, and I said, oh, I like this, I like that. And nothing really said this is what you want to do until I reached surgery. And then I was sitting on a dock in Cooperstown, New York, on Lake Otsego, where I had an externship at the Mary Imogene Cooper Hospital, and I had a long list of all the rational reasons I should go into internal medicine. I had a very short list of all the rational reasons I should go into surgery. And Emily said to me, follow your heart. And I said, that's it. No more conversation. I'm going to be a surgeon. And of course, I've never looked back, and I've been extremely happy. Now, Emily, on the other hand, originally wanted to become a doctor. But very, very early, she started to publish. And she was published in Harper's, and she won all the poetry contests at Barnard. She was offered a summer externship at Mademoiselle. If we had stayed in New York, she probably would have had a very, very high position in one of the leading magazines like the New Yorker and so on. And then, in addition to her ability to be a writer, she became an editor and a publisher. She founded, as you know, Milkweed Editions, retired from Milkweed Editions, which she blames totally on me, because I was talking retirement, but I was talking the talk, but I didn't walk the walk. I'm still on the full-time faculty. And so when she realized I'm not going to really retire, she started her other publishing company, Griffin Press, which is now becoming a very successful children's book press that publishes books on animals and with a lesson, like don't chain your dog, spay your cats, and so on. and she's getting a great deal of recognition from this. Well, so we've both had careers, continue to have careers, and why? Because we both enjoy what we're doing. And we haven't lived our lives saying, oh boy, we can retire. We've enjoyed what we're doing. The products are nice, but the best is the process. The process of doing the work of writing, publishing, doing research, going to the operating room. It's the process that counts. So we've had careers. It's never been a question of one of us shouldn't have a career. And we've managed, and I think probably reasonably well, to raise a family of 4 wonderful kids and 6 grandkids, and we're very close to them, and I think we've done that as well, and that's sort of been our joint career. I remember many times when one of our children was in a gymnastics meet or some other activity, and I never could make it home in time for dinner, but I made it in time for the meet. And so there I was sitting with Emily, and it was now 7, 8 in the evening or something, and she passed me the sandwich because I couldn't. That was my dinner, but I was at the meet. And so I think we managed to do it. We managed to raise a family, have fun, have many dogs, have fun with them, and yet have independent careers, which were never a question that it wouldn't happen. And maybe it's a good thing for a couple to have independent careers and sit down at night and say, what did you do today? And have an interest in each other's work and tell each other what they've done.
Any lingering regrets about the writing?
I'm sorry?
Do you have any lingering regrets about the writing? About not having followed up that particular impulse?
Well, no, because I've done it. I continue to do it. I have well over 300 papers and many book chapters and 4 books. And right now, I'm writing a column for General Surgery News, which is the largest circulation newspaper like that on my desk that goes out to all surgeons. And I write a column every other month, and I enjoy that very much. And I'm about halfway through writing my memoirs, and I enjoy that. And so I haven't given up the pleasure of writing.
I've been doing these interviews now, depending on how you count, 20 or 30 years. And one recurring question for me as I listen to them, review them, is something about legacy.
I'm sorry?
About legacy, that is, about the way that people draw from their families, and maybe from grandparents, and maybe from well-established traditions, and also the way they send that forward. Where what's sent forward might not be medicine, might not be surgery, might not even be science, but something comes forward. Something gets passed on. And I'm wondering if you've thought at all about thinking about your own family and what happens with them, and this very strong interest you've had and strong optimism you've had about solving pretty important and hard problems. How do you see what it is you pass on?
You ask tough questions. Well, I think though we spent this time talking about professional career, I don't put that at the top of the list. I put at the top of the list love and family. There is nothing more rewarding and making happiness and everything else that is good in this world than the love between people, particularly, and certainly in our case, the love between man and wife. I think that if you can achieve a relationship of love that lasts for a long, long time, that's maybe the greatest accomplishment. The word accomplishment is even a bad word. It's the greatest joy. And that, of course, extends to your children, grandchildren, people who become your children, son-in-laws, wife, husband, family is at the top of all aspirations. And if there's a legacy to pass on, Emily and I hope we can pass on that feeling of family and love. I guess after that would come what a word I used before, process. Doing what you're doing and enjoying it. I've always been dismayed when I walk down the hall and I run into somebody and I said, "How are you?" or "Hello, good morning." And they answer me by saying, "It's Monday," or "Thank goodness it's Friday." And I think that person is living 5 days of the week to do whatever they do on Saturday and Sunday. And isn't that sad? They're spending the greater part of their lives doing things that they hope they could stop as soon as possible, and they don't enjoy. So I guess a legacy to pass on is to enjoy the process. And whatever that is, be it medicine, be it writing, whatever, be it being an athlete, but enjoy the process. And again, as I said before, the outcomes are nice, but they're never as important as the process. Example, I write a paper or write a column now. I enjoy seeing it in print, but I barely look at it once it's in print. But I enjoy doing it. So it's the process that's important, and that's where the joy should be. And we like to pass that on. Emily has big letters in our dining room that says "Now," N-O-W. And living in the now, or living in the process of the now, rather than in the past or continuously dreaming of something that may or may not come, is part of that joy in the process. So I guess that would be something we would like to pass on. My own professional life, if I've one thing that could be said to be something, is a reverence for life. I think the first role of any physician, be it a surgeon or whatever specialty, is a reverence for life. We should always be on the side of preserving life and doing the best for our patients that life is meaningful. And that's, I think, the the soul of being any kind of physician.
As I've been sitting here, I feel a friend, invisible, tugging on my sleeve. You've got to ask him about animals. And in this connection, you are married to a passionate advocate for the welfare of animals, especially dogs. I mean, I have to restrain either myself or my wife 3 times a day from going out and adopting some animal that Emily has put on Facebook as in grave danger. And I know that surgery progresses by animal experiments, and by you don't do your first practice run for a surgery on a human being. I'm wondering how you think about that in specific, whether you think that there are ways of diminishing the suffering of animals that is part of medical progress.
Well, I think that is the spirit of today. It wasn't the spirit of yesterday or yesteryear, but today I think that's very, very much the spirit. And we have a whole host of tools that we can use to achieve that. First and foremost is, of course, the computer. We can do computer simulation. We can do all sorts of 3-dimensional studies on a computer. We can set up all sorts of problems on a computer. I've always said a great benefit of a computer is that you can ask it stupid questions. Before we had computers, we couldn't ask stupid questions, because you'd ask a question and it takes 6 months to come up with an answer that was meaningless. Now you can ask a computer 100 stupid questions, and the computer within 24 hours will give you answers to all of them, and one of them might be meaningful. So the idea of using computer simulation for animal studies, I think, has done a great deal for minimizing using animals for actual experiments. I think also that there is a phase in which we do trials on human beings that aren't going to harm them, such as a patient comes in for a certain operation, and with true informed consent we ask, would you mind if during this operation we introduce this instrument to see if it works? It's not going to be part of your operation, it's just going to prolong your operation for 5 minutes or so, and there's really no safety risk involved. And most people will say yes. And you learn so much more from that than you do by operating on an animal. So yes, we're trying every way possible today to limit animal surgery. I don't think it can be totally eliminated. I think that still there's going to have to be some testing that is done, and but there's going to be less, and we hope it's going to be worthwhile and won't be for frivolous purposes.
I've always, from the outside, been amazed at surgeons because they seem to have to combine two areas of skill that don't necessarily go together. Good hands, clockmaker, watchmaker, good hands, and a certain kind of intellectual overview. an ability to see how this stitch fits into this body, fits into this life, fits into, in your case, the progress of an area of medicine. How do we find the next generation of academic surgeons?
I've just written a column about that. What makes a surgeon? Well, I feel there's certain genetic traits to start with. Now, I'll say this about almost everything. Take certain genetic traits to make the star athlete. Whatever. I think a surgeon has to be born with a sense of independence, stamina, a certain amount of hand-eye coordination. You can teach almost anybody to operate, but if you start off basically with hand-eye coordination, it becomes easier, and maybe you become better. I mean, it's like being an athlete. You can teach anybody to play ball, but some people become better because they start out with some sort of natural ability, and they instinctively move towards the ball. They instinctively, for a surgeon, has hand-eye movements. Anybody can play ball, but some people do it better. And I think the same is true for surgery. So I can list a whole bunch of things. I think the major test comes if you go so far as to say, well, I want to go into medicine, let's go to medical school. And then I think the operating room is the major test. You have to feel comfortable. And more than that, you have to feel happy. You ask anybody who's been a surgeon all their lives, like myself and others, how do you feel about your time in the operating room? And you'll get an answer, it's a sanctuary. It's a home away from home. I'm so happy in it. I'm certainly there's maybe in an element of tension, but it's a place you feel comfortable. It's a place you feel this is where I belong. And I think that's what very much makes that final decision for people to say, okay, I'm going to become a surgeon. That's what I want to do.
Last question. What's your operating room like? How do you, I mean, you walk in, what's the feel of the operating room that you inhabit?
Oh, there are, well, let's go back. When I first trained, there were very rigid operating room rules. No talking except pertinent to the case, certainly no music, etc., and so on. I think the rigidity has gone out of it. I still wouldn't like nonsensical babbling about what you're going to do this weekend and so on, etc. But I think chatter is all right, except if something becomes critical, and then I stop chatter. And then we concentrate on only what we're doing. And a little talk is fine. I think playing music is fine. So I think the operating room should be a relaxed atmosphere where people know what they're doing, comfortable doing it together as a team. And of course, my bias is, yes, it's a team, but there's one person in charge, and that's the surgeon. Now, of course, the anesthesiologist would disagree with me, but that's my feeling about an operating room.
And a very last question, which music?
Oh, I like opera or some classical music, but ever so often I give in to the tastes of everybody else in the room, and we have some country western or whatever else.
Thank you.